Hello, my name is Dr. Laura Palmer. I'm a neuropsychologist in Madison, New Jersey. The title of this presentation is Love and Meaning in the Time of COVID for the Old and Very Old, exploring the relationship between aging, emotional, cognitive, relational, and organizational factors, and psychological survival during the pandemic. The purpose of this presentation is to provide you with a review of our experience as psychological consultants working within a continuum of care retirement community across the pandemic. The threat of infection, experiencing COVID-19, deaths of family and friends, social isolation, limited access to healthcare services, social support, recreation, spiritual support, are some of the many key factors which have converged, representing a state of prolonged psychological distress for our residents. We have worked within a disaster response framework as psychological first responders and have been in a constant state of assessing those in the most urgent need, as well as those at the greatest risk of harm or deterioration, providing psychological first aid as well as secondary and tertiary prevention services at the individual level, as well as for family systems and the organization. At the same time, maintaining an eye on self-care, compassion fatigue, and team support. So spend a moment giving you some sense of context about who we are, where we work, who we work with, and how we approach the work. I had the opportunity in 1997 to establish the Psychological and Neuropsychological Services Consultation Project when I was Director of Training at the Counseling Psychology doctoral program at Seton Hall University. At that time, we were able to introduce our students to geropsychology and geroneuropsychology. I'm no longer affiliated with the university, but we continue the consultation services, and at this time, we have 3 licensed psychologists, all of whom are Medicare providers, and 2 interns, and 1 Dorothy D. Palmer Fellow in Optimal Aging. We also, 5 years ago, established a primary service component in animal-assisted interventions, and we have 1 canine therapy associate, Bonnie Prince Harry. We are fortunate to be able to provide a comprehensive range of psychological and neuropsychological services at a CCRC located in Maplewood, New Jersey, which is in Essex County. This is important to know because we were one of the counties in which we had a very high rate of infection as well as deaths resulting from COVID-19 in the early stages of the pandemic. The facility is a not-for-profit organization. It's previously an independent retirement home, and we have been present across the transformation into a state-of-the-art CCRC, providing services for residents to age in place with housing including independent living, assisted living and long-term care, a memory unit, and a skilled nursing facility. I think it's important to kind of take a moment to review who we work with. So we do consider the residents of the CCRC our primary client base, but we also provide support services to staff as well as family members of the residents. The median age across the facility tends to be amongst the older old and very old. Again, the median age is around 85 plus. The age range across the facility can be, the younger end would be around 68 to 107. Most of the residents in the assisted living and long-term care are single, either widowed, divorced, or never married. Although we do have some individuals who reside in AL or long-term care with partners residing in independent living or outside in the community. The independent living, there's a different distribution with more couples along with single males and females. We don't have a count or accurate knowledge of the number of trans or intersex individuals living in the community. Gender is a relative distribution of men and women with some restricted distribution on race, ethnicity, and sexual orientation, although that is slowly evolving and diversifying. The educational level tends to be quite high, particularly in independent living, with the median range from 16 to 20 years plus. The staff, we have a staff of approximately 150 full-time, part-time, and per diem, with an age range much younger than our residents, with 18 to 65. The median age differs across departments. Gender distribution, there tends to be a higher number of female to male in nursing, as well as nursing aides, housekeeping, and culinary services. There is a higher degree of racial, and ethnic, and cultural diversity amongst the staff. And the level of education really varies with the employment position. As I mentioned, we also provide a range of services to family members of our residents, including caregiver support, consultation services, and family therapy. I believe it's important to spend a bit of time looking at the theoretical and logistical factors that inform and direct our work. From the conception of the consultation service, the overarching guiding theoretical framework has been one of a biocultural, political, psychosocial model of development. We'll return to that in a moment, as well as theories and research information on factors affecting optimal aging. My long-standing research has been understanding stress, acute stress, traumatic stress. So stress awareness and stress management has been a core component of our work. Working within a disaster response framework as psychological first responders has become a guiding framework for us across the pandemic. As I mentioned earlier, animal-assisted interventions, animal-assisted therapy has been a core component of services for the past 5 years. And recognizing and attending to compassion fatigue in ourselves as well as to caregivers and staff members has also been a critical aspect of our clinical service delivery across the pandemic. As I mentioned, the biocultural, political, psychosocial model of development has been an overarching theoretical guide for my work for the past 30 years, largely based on Erik Erikson's work and Carol Gilligan's reshaping of the original theoretical perspective. We understand that the individual is always undergoing active change and development across the lifespan, being affected by a multitude of factors impinging on the sense of self and self in relation to others. This diagram captures just some aspects of the complexity of this very dynamic process, again, that occurs across the lifespan. We think of successful aging in many ways as the absence of disease and disability, high cognitive and physical functioning, and active engagement with life. That's perhaps an aspiration or an ideal. Optimal aging goes beyond good health and longevity. It deals with the capacity to function across many domains: physical, functional, cognitive, emotional, social, and spiritual. This capacity is rooted in the concept of adaptation. The many changes of life itself and the frequently accompanying vicissitude of illness, functional loss, changes in the family, economic struggles, and other stressors, most specifically the pandemic, offers opportunities to adjust and adapt. Optimal aging accounts for the tremendous inter-individual variability and intra-individual plasticity. The adaptation that older adults make to the many changes of aging involves selection, optimization, and compensation. A person may select certain activities that are most satisfying and meaningful, and behaviors can be modified to optimize performance in these activities. When capacity is lost or reduced, an older person can compensate by choosing different methods of accomplishing the task or altogether different activities. Optimal aging should be seen from a biopsychosocial viewpoint. It doesn't require the absence of disease or disability. In fact, these problems can be viewed as opportunities for growth and development of new capabilities. It utilizes a systems perspective where lower levels of the system affect higher and vice versa. A particularly useful model for explaining the interrelationships of various aspects of the biopsychosocial approach to optimal aging has been found in the health field model called Determinants of Health. In this model, all aspects of the disease-health continuum are addressed, including the patient's genetic endowment and behavior, the social environment and support system, psychological resources and stressors, the physical environment, and the healthcare system. This is true also in the way we approach optimal psychological and cognitive aging in our psychological consultation service here at the CCRC. Cognitive well-being is the primary focus of our work in the consultation services at the CCRC. Cognitive well-being in aging is associated with increased cognitive activity, in that cognitive stimulation in one's environment is a crucial predictor of enhancement and maintenance of overall cognitive functioning. Other key factors include increased and maintaining relatively high levels of physical activity, social engagement and support, nutrition, and good sleep hygiene. There are known physiological risk factors associated with cognitive decline in aging. Certainly, aging itself is one of the primary factors. A history of traumatic brain injury and diabetes, high blood pressure, high cholesterol, and high levels of homocysteines, poor diet, lower levels of education, low levels of exercise and inactivity, and more limited access to social engagement are some of these key factors. As I mentioned earlier, stress has been a primary focus of my research, clinical practice, and teaching for the past 30 years. Chronic exposure to stress hormones, whether it occurs during the prenatal period, infancy, childhood, adolescence, adulthood, or late life, has an impact on brain structures involving cognition and mental health. The specific effects on the brain, behavior, and cognition emerge as a function of the timing and the duration of the exposure. Some effects also depend on the interaction between gene effects and previous exposure to environmental adversity. I will briefly review a few other key theoretical frameworks and experience that informed our preparation as well as our ongoing service delivery across the pandemic. These include gerotechnology, the concept of psychological first aid and a disaster response framework, recognizing and attending to compassion fatigue, systems theory and how that impacts service delivery in a CCRC, and animal-assisted interventions and therapy. Just briefly, gerotechnology is thought of as an alliance between gerontologists or geropsychologists, technologists, aimed at improving services for older adults through the use of technology. Information and communication technologies include tools aimed at communicating and informing, such as the internet, telephone-based support groups, voice technology, webcams, and online computer games. Assistive technology refers to computer-based tools designed to maintain and prolong older adults' independence, to stimulate their mental agility, to create networks to keep in touch with others, and to reduce feelings of isolation, as well as to increase a sense of security and welfare. Obviously, these have been critical goals for the use of technology across the pandemic as a means of sustaining and optimizing aging as well as psychological well-being in our residents. The intervention target areas of gerotechnology are commensurate with our overall intervention target areas of our psychological and neuropsychological consultation services. These include maintaining and enhancing cognitive functioning, supporting, facilitating communication, improving or sustaining a sense of psychological well-being, facilitation of social engagement, assistance with behavior management, as well as stress management. To elaborate on these organizing foci in our work, psychological first aid refers to an initial disaster response intervention where the goal is to promote safety, stabilize survivors of disaster, and connect individuals to help and resources. Psychological first aid is delivered to affected individuals by mental health professionals and other first responders. Systems theory allows for a focus on needs at the individual, family, and organizational level. An appreciation for systemic factors prevalent in CCRC settings has been crucial to anticipating and providing therapeutic services during the pandemic. Compassion fatigue is another area of primary concern. Compassion fatigue is a condition characterized by emotional and physical exhaustion leading to a diminished ability to empathize or feel compassion for others. It's often described as the negative cost of caregiving. It is sometimes referred to as secondary traumatic stress. Professional burnout and secondary traumatic stress are two interwoven elements of compassion fatigue. Animal-assisted interventions and animal-assisted therapy has been a cornerstone of our consultation services since March 2016, when I was fortunate to secure Bonnie Prince Harry as our canine clinical associate. He is trained and certified as a therapy dog and has been providing and continues to provide individual and group support services at the CCRC, as well as many different forms of special events. There are several key logistical considerations that has assisted in our capacity to provide optimal patient care across the pandemic. One, of course, is a 24-year experience working within the system. to be able to provide the essential gerotechnology services and to provide ongoing psychological and neuropsychological support services virtually, it was very beneficial to have had a foundational baseline level of tech skill efficacy within the community, primarily within the independent living community, but to a lesser degree also within the assisted living community. Certainly the pre-existing and long-term relationship has afforded us stronger collaboration, communication, and capacity to work across an interdisciplinary team approach. And most especially critical is the capacity for recognition of compassion fatigue and the engagement in self-care and team support. I'll briefly discuss the anticipation, impact, response, logistics, and efficacy that transpired in our work across this pandemic timeline. The process of anticipation, preparation, and action moved quickly with the onset of the pandemic. In New Jersey, the first case of COVID-19 was announced March 4th. By March 18th, there was executive orders closing schools, placing a moratorium on in-person instruction at institutions of higher education, and clear directives for long-term care facilities. At our program, March 6th, we were following those early CDC recommendations as far as just avoiding close contact, washing hands, avoiding touching your face or mouth. Masks were not recommended or required. That changes quickly. By March 10th, there was a scramble for supply of PPE for staff. And by March 19th, there was suspension of all non-essential services at the CCRC, including psychological services. For us, our last day of in-person services occurred March 18th, 2020. We were able to return for limited in-person services, primarily individual therapy services, June 10th, 2020, while group services and activities remained virtual until April of 2021. So again, with impact, by March 13th, 2020, the facility had implemented a strict non-essential visitor policy for assisted living and all healthcare programs, which included family members. Telephone contact, using Zoom contact, social media and technology was available, but no physical contact, which was very frightening for many, if not most, of our residents. By March 19th, all meals had to be delivered to the residents' rooms or apartments, so the primary form of socialization and interaction in the community, which is mealtime, was suspended. Residents were now required to shelter in place and stay in their apartments. There was a cancellation of all public or non-essential group activities, as well as non-emergency maintenance, housekeeping, and salon services. So virtually all physical contact with the outside world was cut off. Finally, by May 13th, 2020, there was testing mandated for all the residents and staff of long-term care residents in New Jersey, which the CCRC where we work, complied with. This did not, however, initially include independent living residents. So monitoring and impact as far as infection rates and deaths, as of the cumulative totals from March 1st, 2020 to June 4th, 2021, there was a recorded number of 11 cases of confirmed infection in our healthcare facilities of COVID-19, with a reported 9 who recovered and 3 deaths. There were 10 non-CCRC confirmed cases of infection. These were direct admissions from hospitals or private homes to the healthcare facility. 8 of these individuals recovered, 3 did not. There were 38 staff in total who contracted COVID-19, all of whom recovered, although there are a number of individuals reporting ongoing symptoms of cognitive and physical sequelae to COVID. As for our response and the logistics involved, the last day we were able to provide in-person services was March 18th, 2020. Our psychological consultation services is typically only available 1 day a week at the CCRC. We have been providing instruction and gerotechnology services in a research-based program for the past 7 years. So there was a core group of residents in independent living and a few in assisted living proficient in the use of various technologies, including social media. But we wanted to make sure that there were a larger number of residents who could maintain contact with their family as well as medical providers through the use of technology. So we developed and initiated a series of Zoom training for residents, with the first session held virtually April 1st, 2020. We were able to continue our brain fitness program, which meets weekly in a virtual medium beginning April 15th. We established CARES, which is an online support group for residents to address anxiety and coping during the pandemic. That initiated the second week in April and met weekly through June. We have a pre-existing adult child caregiver support group which had met monthly. This was extended to weekly virtual meetings as of the first week of April. I trained Bonnie Prince Harry to meet with residents virtually and set up our virtual pet therapy visits in assisted living, long-term care, in the memory unit beginning early April. The practice chose a virtual therapy service where we could meet with individuals with greater HIPAA assurance than Zoom offers. We developed and provided mechanisms for staff support and recognition, maintained informal communication with staff and administration to provide support and monitor residents needing services, as well as to provide staff support when indicated. We returned to in-person services June 10th, 2020. All groups remained virtual until April 27th, 2021. The adult child caregivers group will probably remain virtual indefinitely because it allows for greater participation from family members across the state and also living outside the United States. So how did our patients respond? We had those who thrived, those who were able to maintain equilibrium, those that languished, and some who declined. The individuals who thrived were likely resilient and hardy pre-pandemic. They also displayed what's been referred to by Tedeschi as post-traumatic growth factors. This includes such things as appreciation of life, capacity to form, maintain, and strengthen relationship with others, the capacity to see new possibilities in life during and post-adversity. They tend to display an overall sense of personal strength and capacity for spiritual change and adaptation. We also had those who tended to maintain equilibrium, neither necessarily thriving or declining. These folks tended to utilize and maintain existing support and coping systems, or they had some capacity to improvise. We also had individuals who were less inclined or dependent on social engagement, or were perhaps socially avoidant pre-pandemic. These individuals were generally content to manage without the pressure or expectation to engage in social activities. And then we've seen these individuals, both our residents and patients, as well as staff and colleagues, who languished. So languishing has been referred to by Corey Keyes, a sociologist, as a psychological state closer to the negative end of the spectrum of mental health, but not far enough to be considered major depression or psychological illness. It's been described as a state of emotional, spiritual, or psychological emptiness, stagnation, or quiet despair. And it has been found to be a risk factor for major depression. During the pandemic, both as providers but also our patients, colleagues, we've become low on the psychological fuel that we need to operate optimally, which comes from new experiences and rest, as well as overall, at least a moderate level of optimal functioning. Flourishing is a state of where people experience positive emotions, positive psychological functioning, and positive social functioning most of the time, living more or less within this optimal range of human functioning. It is a descriptor and measure of positive mental health and overall life well-being, and includes multiple components and concepts, such as cultivating strengths, subjective well-being, goodness, generativity, growth, and resilience. Flourishing has been conceptualized by Corey Keyes and Barbara Fredrickson as the opposite of both pathology and languishing, which are described as living a life that feels hollow and empty. It is a central concept in positive psychology. This concept of languishing versus flourishing is worth further consideration. Again, the languishing, as Corey Keyes has referred to it, is considered like the neglected middle child of mental health. It's the void between depression and flourishing, the absence, if you would, of well-being. You don't necessarily have symptoms of mental illness, but you're not the picture of mental health either. Languishing can dull motivation, disrupt ability to focus. It appears more common than major depression, but in some ways it may be a bigger risk factor for mental illness. We are particularly concerned about the long-term impact of the pandemic on mental health, and from what we're seeing, that more individuals are really falling within this category of languishing. The concern herein is that the longer we are in this state of pretty much suspended animation, capacity to fully re-engage in life, or to at least begin the process of re-engagement. I fear that the more we're going to see this depletion of psychological and emotional resources, resulting in languishing, and long-term without intervention, then leading to higher levels of depression, and with our older adults, higher levels of cognitive decline as well. Stress and anxiety has been a primary area of focus across my professional life, including research, teaching, and clinical intervention. We are also critically aware of the relationship between unmitigated stress and anxiety and the impact on cognitive functioning and optimal aging. Stress awareness and management is considered to be a first-line defense against COVID-19, in that unmitigated stress and anxiety lowers one's immune system and resistance to infection. It can also exacerbate the deleterious effects and ongoing effects from infections such as COVID-19. We provided ongoing weekly anxiety support groups for our residents, as well as increased the caregivers support groups to weekly meetings, and provided psychoeducational programs and materials to residents, caregivers, and staff members addressing stress awareness and management. One resource that we found through a group called Help Guide was Coronavirus Anxiety, Coping with Stress, Fear, and Worry. You'll find this reference in the resource materials provided. Have we been effective? Well, what we've seen and what we've been told is that overall our services have been beneficial, if not essential, to our residents, to staff, and to family members. Evidence-based practice is based on evidence from scientific inquiry, clinical expertise, and client perspectives. We have not been able to subject our intervention services to scientific inquiry at this point. So the indications of program efficacy are this. We've had a high rate of retention of patients and clients in our service. We've had both continued and increased utilization of services by residents, by staff members, and by family members. We've had a high level of retention of our team members. We have evidence of client and patient utilization of available resources, not only our therapy services, but also group support and psychoeducation materials. We've maintained our capacity to monitor, anticipate, and address patient status and patient needs, and to respond to crises as indicated or requested. Our team members are thriving. We've had a 0 infection rate in our team, and 100% of our team is vaccinated. Most of us being able to access our vaccination through the CCRC. Patient, staff, and administration provide ongoing positive appraisal of our services and initiatives. Self-review and team assessment would also suggest that we feel we have been able to work at, if not beyond capacity, to anticipate, develop, and facilitate as many initiatives as we could conceptualize that would be beneficial to the multiple constituencies we serve. I'm going to briefly review now lessons learned and future directions. Psychological, recreation, and social support services need to be considered as essential and provided for in any type of disaster response plan at a CCRC. We've come to recognize, and research tells us, that disposition, previous experience with adversity and trauma, and pre-pandemic situational factors all serve to mediate the psychological impact on individuals. Stress and isolation has long-term deleterious impact that is not easily, if at all, remediable on the more vulnerable members of a community. This is particularly true for individuals who are at mid to late stage types of dementia. We found that technological efficacy, accessibility, and tech support is essential for the community, for residents to be able to access all forms of services and support that will help maintain psychological well-being and safety across the pandemic and other forms of prolonged disasters. Caregiving of the caregiver and frontline staff has to be a primary concern of any organization. Prioritizing health, both physical and mental, and safety of caregivers, staff, and essential workers has to be immediate and transparent. Ongoing staff support and stress management, again, has to be built into the framework of the organizational structure and HR response. Establish and maintain communication channels for family and professional caregivers with administration has been seen as essential to the ease of anxiety, both for our caregivers, family caregivers, residents, and staff. The psychological support services has to include stress management and inoculation, acute stress support services, bereavement support. I would also add that suicide and risk assessment has to be available, and processes to maintain, without interruption, ongoing psychological support for clients previously in the service. Maximize access to in-home social engagement, recreation, exercise, cognitive stimulation, and continuation of services. Again, this is most likely going to be linked to available, accessible, and supported technology. Therefore, technological training and in-person support has to be an essential part of the package for residents and staff of all CCRCs. There are numerous diversity and equity considerations. Dr. Dunn, in her introduction, has addressed some of these that are ongoing considerations and in many ways real challenges for service delivery, equitable service delivery for residents as well as our staff. These include cultural and socioeconomic factors, sociocultural racial differences that exist between staff and residents, both inter and intra individual ageism as well as ableism are just a few of these factors that we address and consider every day. Statement of affiliation and disclosures. We have been consultants at this particular CCRC for 24 years, providing a range of psychological and neuropsychological services. Our arrangement with Lumosity has been as a provider of a cognitive platform of games supporting a research project on which I am the primary PI that originated in 2014. And this is an ongoing collaboration.
Thank you for your attention. You can reach me at psych@drlaurapalmer.org. The contact information will be in the resources and the slides. I welcome your comments, feedback, or questions. Until then, stay safe, and thank you very much.